Hey everyone, today we're going to be talking about Chapter 14, which is patient monitoring and local and regional anesthesia. We will define some terms and abbreviations, explain different patient monitoring devices, and discuss MAC anesthesia. The surgical technologist every day is going to see anesthesia administered in the operating room, so it's going to be important that you guys understand what they're doing and some terms related to that. Auscultation is a non-invasive measure to assess the patient's heart and lungs. Blood pressure is the measure of force of the blood against the vessel walls. And capnometry is the measure of how much carbon dioxide the patient exhales. Electrocardiography, or ECG, we typically refer to it as EKG. This is a way to monitor the patient's heart rhythm and rate. Epidural is a term used in conjunction with anesthesia. It generally refers to the injection of an anesthetic agent into the space surrounding the duramater. And exsanguination. This means to render bloodless. Typically, we'll do this through a tourniquet, which we'll talk about later. Intrathecally is a term used with spinal anesthesia, referring to the location where the anesthetic agent's administered. Local anesthesia is the administration of an anesthetic agent to nerve endings in the surgical site. And MAC, or monitored anesthesia care, is defined by the American Society of Anesthesiologists. And this includes varying levels of sedation, analgesia, and anxiolysis. The anesthesia provider monitors all vital signs continuously during these procedures. Pulse oximetry is one of the most common physiological functions monitored in surgical patients. This is the saturation of oxygen in the blood. And regional anesthesia is administered at a group of nerves called a plexus. So now we're going to kind of move on and talk about patient monitoring. So there's a lot of different ways that we can monitor patients preoperatively, during operation, and afterwards. So it's going to be really important that you guys are able to define, explain the purpose of, and give some details about patient monitoring devices when you're talking about them. The first line of patient monitoring is going to be direct observation. This is just the way that you're observing the patient, kind of just see how they're doing by looking at them. Certain patient conditions and some procedures are also going to require advanced or invasive monitoring methods. But the basic ones that we're going to monitor in surgery are that EKG, oxygen, blood pressure, temperature, carbon dioxide output, and BIS monitoring. First, let's talk about electrocardiography. Your book refers to this as an ECG. I will probably mostly refer to this as an EKG, just because that's the way we use it. It's just the way to record the heart's electrical activity. So it kind of tracks the rate and rhythm of the heart, and you want to continuously do this during surgery to make sure there's not any problems happening. Electrodes will be placed on the patient. Typically, we use what's called a 3-lead, so they will have 3 stickers on them. Sometimes you have some anesthesiologists that prefer a 5-lead, so they'll have 5 stickers placed on them. And then this will transmit impulses to the EKG device. It'll be recorded and displayed on a screen. It can also be set to record on tracing paper that will print out, or a lot of times now in this day and age, everything goes to a computer and it can be recorded there. And it will typically emit an audible signal to indicate heart rate. So you're going to hear like a beep, 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 and the faster it beeps means the higher heart rate, and then a slower beep, like a beep, 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 that indicates a slower heart rate. Also with this, you can supplement it with auscultation, which just means listening to the sounds of the chest with a stethoscope as well. The next monitor we're going to talk about is pulse oximetry. This is a non-invasive measure of oxygen saturation of the blood, and the big purpose of this is to assess respiratory function. With this, a sensor probe is attached to a finger, toe, or earlobe. You can see a picture here. This is a two-sided probe that's on a finger. This is a non-disposable device, so it would just go directly to our machine. A lot of times you'll also see ones, we have stickers in surgery that just stay with the patient and then hook up to our cord, and that can follow them to the recovery room as well, and they can keep using that same sensor and hook it up to our the tubing, whatever you want to call it, the cord. Um, Also, sometimes if patients are really, really cold, they may not get a good reading on that pulse oximetry on a finger. Nail polish can sometimes interfere with that too if it's really, really dark. So that's when they might use an earlobe probe, and it's just a little click that goes on the ear to get that oxygen saturation. So how this works is the sensor is going to emit red and infrared light, which is absorbed while passing through tissue. So the remaining light's detected by the opposite side of the sensor probe, and then that is used to calculate the saturation of oxygen. So it's pretty complex. I don't expect you to know the details, but that's exactly how it does work. In our patients, ideally, and even on the floor, we want that level of saturation to be over 95%. Um, Sometimes when you're using IV dyes, that can affect the reading, but most of the technology we have today is capable to adjust to that, so you're not going to get a strange reading from it. Also with this, it does have an audible signal to reflect that pulse rate that'll indicate saturation. The deeper the tone, the lower the saturation. So if you hear that getting really deep, that's bad. And then again, readings can be affected by various factors, but this will just be another sound that you hear in the operating room. On this slide as well, you can see that picture of the sticker probe that we sometimes use, and this is what I talked about that can hook up to our cord in surgery. But one side goes on the fingernail, and the other side just kind of bends over and wraps around almost like a Band-Aid on the patient. Blood pressure. This is one that you guys are probably very familiar with just from, your routine doctor's appointments and things like that. This is just another way to monitor the patient, and it's a measure of the force of blood against the vessel walls. The big purpose of this is to monitor cardiovascular status. Normal blood pressure for most adults falls within a range. It can be affected by a number of factors though. Normal range is going to be less than 120 over 80. An inflatable cuff will be placed on the patient's upper arm, and it'll automatically measure that at set intervals. And then again, if it's not within preset limits, you will get an audible alarm on the anesthesia machine. Blood pressure can be affected by some different factors, such as ventricular contraction strength, capillary resistance, vessel wall elasticity, and blood volume. Another thing that we will monitor in patients in surgery is temperature. So this is important because all patients that undergo general anesthesia are at a risk of mild to significant hypothermia. So that means just their temperature could drop too low. So the thermometer will measure temperature. There are different ways to measure the temperature. I said a thermometer, but that's not necessarily the way we're going to do it in surgical patients because, again, they're asleep, so it doesn't quite work like that. Patients that are at risk mostly for hypothermia are going to be pediatric and geriatric patients. So they're going to be a little more important to monitor than some other ones. And then it also helps us to check how effective we are at our heat loss prevention measures. We have different things we may do in surgery to keep a patient warm. We may use warm blankets on them. We can use what's called a bear hugger. It's something that goes on the patient that circulates warm air over them. We like to use warm irrigation in abdominal cases. All of those things can be done to kind of prevent that heat loss. So when we are monitoring temperature, we can do this a couple different ways. We can measure at the skin. So what you'll see, that right lower picture is a forehead strip. This can go on the patient and it gives the anesthesiologist a general idea of temperature. Axilla, so that's going to be armpit. We can also measure it a little more invasively, so through the bladder, esophagus, or ear. So for measuring through the bladder, we'd use what's called a temp sensing Foley catheter, and that's that picture on that bottom left. Just like a regular catheter, it's going to have an extra connection to it that will transmit temperature so we can see what it is invasively like that. Also, the middle picture here is an esophageal temperature probe. So this can actually run in conjunction with an endotracheal tube. You can place it down next to it kind of into the esophagus, and it'll help to measure temperature there and transmit it back to the anesthesia machine. The normal body temperature is going to vary, of course, individually. Normal temperature is going to be near 98 degrees Fahrenheit or 37 degrees Celsius. So typically what they'll do is take a baseline measurement for that person and then monitor any changes from that. Capnometry, so this helps assess respiratory function and can serve a critical role in the early detection of some emergent conditions like compromised ventilation or malignant hyperthermia, which is that too high body temperature, which we'll talk about in the last chapter. So this involves extending a tubing from an adapter on the ventilator tubing that the patient is hooked up to the machine, and it'll give you a printout reading here that tells you exactly what their exhaled carbon dioxide is. Basically, they just continually is graphed, so as they exhale, it'll show that carbon dioxide on the screen, and then as they inhale, you'll see that level drop down. It also gives you a numerical value. Typically, the normal range is going to be 35 to 45 millimeters of mercury. Anytime you see a higher level on this, it can mean that they are having hypoventilation or not getting enough air, or it can also indicate increased metabolic activity. And then if you see that number low, it might mean they're hyperventilating. Also can mean decreased cardiac output, poor pulmonary perfusion, maybe even shock. So those are some things that they might look into if they get some strange numbers that's not normal. Okay, and then another monitor we might do in the operating room is monitoring consciousness of the patient. So we can use what's called a modified EEG to help determine the patient's level of consciousness during surgery. So you might have heard of awareness under anesthesia. It's a rare complication of surgery, but it is significant concern because you don't want your patient to be aware of what's going on when they're being operated on. So we can use this to attach to the patient's forehead to kind of monitor that. So the sensor just kind of sticks on there and it's hooked up to a machine. It'll interpret and display a reading between 0 and 100. A number near 100 means the patient's fully awake, and then anything less than 60 will show an appropriate depth of general anesthesia. It means they're probably not going to recall anything that's going on. And we typically refer to this as a BIS monitor in surgery. We might also monitor neuromuscular function on patients. When we are giving general anesthesia, a lot of times, or all the time, muscle relaxants are given to allow intubation with an endotracheal tube. So they can use what's called a nerve stimulator to assess that neuromuscular function as well to see how relaxed that patient actually is. The picture here is of a nerve stimulator. This is kind of an older model. You might see some newer looking ones. This just helps to assess that muscle relaxation like I mentioned. So a surface electrode or probe is going to deliver a little stimulus. They do what's called a train of 4, where they will check to see at what point they're responding to the stimuli, basically. So if they respond at 4 different points, there's no muscle relaxation. And then if they're not responding with a twitch response at any of those, there's full muscle relaxation. There's no response whatsoever. And then sometimes we're going to have to do what's called some different advanced monitoring on patients, especially very invasive procedures for vascular procedures, traumas, if we're worried about a lot of blood loss, those kind of things, then a lot of times they want to do some advanced monitoring. So first one we'll talk about are arterial lines. These are placed in the radial artery and connected to a transducer that's going to record the arterial pressure. So it's very similar to blood pressure, what it's measuring, but it's a lot more accurate. And instead of cycling through like every 5 or 10 minutes, it's going to give you a continuous reading of what that arterial pressure is. So it's good when you're concerned about dropping blood pressure really quickly from a rapid blood loss. This is going to be ideal, so you can keep an eye on that. So used for potential or rapid changes in blood pressure. Also, if you need frequent sampling of blood gases, or when that routine blood pressure measurement is inaccurate. So the anesthesiologist may place this while the patient's still awake, or some of them will just wait till they're asleep before the procedure's actually started and do it then. So it's a little more comfortable for the patient. Also, you might see central venous pressure lines placed. So these are also indicated sometimes. They'll be placed in the vena cava. It assesses the volume of blood returning to the heart, and it also assesses the need for fluid replacement and to prevent fluid overload. And again, this is something done by the anesthesiologist prior to the surgery beginning. And then you may also see a pulmonary artery line placed. Swan-Ganz catheter is kind of more of the brand name of this. It's guided through the heart into a branch of the pulmonary artery to measure central venous pressure, pulmonary artery pressure, pulmonary capillary wedge pressure, and cardiac output. This is going to be something specifically used with cardiac surgeries, lung, and liver transplants. So you may never see one of these placed if you're at a facility that doesn't do these transplants or heart surgeries. Okay, and the last type of advanced monitoring we'll talk about are transesophageal echocardiographies, or TEEs. These are used to assess cardiac function. These are non-invasive and basically use sonography to provide an image of the heart, and it's often going to be used with heart surgery. So they will take a special probe that's sent up from central processing to the OR. It's placed into the esophagus, and then high-frequency sound waves are going to be admitted through the tissue, and it helps to just give a real-time observation of the cardiac wall motion and valve function. You can also assess the intravascular fluid volume and identify the presence of air in the heart. So you can kind of see in the picture here where the probe goes through the mouth and down, and then the picture that you get on there as well. So now let's talk a little bit about sedation and monitored anesthesia care. A monitored anesthesia care, or a MAC, this is a specific anesthesia service. It's for diagnostic or therapeutic procedures that can include all aspects of anesthesia, so it's before, during, and after the procedure. The levels of sedation can range from minimal, so basically they're just going to get something to help them not to care about surgery, not to be nervous, moderate, so this is more of a conscious sedation, or deep, where they're not going to feel any pain. So the anesthesia care provider is going to continuously still monitor all the vital signs like their heart rate, EKG, blood pressure, respirations, and O2 saturation during these procedures. So a lot of different procedures are done with the MAC. This can include colonoscopies, EGDs, different scopes like that. So it's important when you're deciding, not you, but the anesthesia provider is deciding whether to do a MAC or general anesthesia, they'll look at some different things. So they will look at the nature of the procedure. How invasive is it? Is it something where incision's being made? Is it going to be something that's really painful? So things like that. They'll also look at the patient's clinical condition. So are they really sick and do they have bad lungs and you would like to avoid putting an endotracheal tube in it possible? That would be a good indication for a MAC. and then look at the potential need to convert to a general or regional anesthetic after that. Different agents can be given during a MAC. So midazolam, which is Versed, that can be given, just they won't remember anything. Fentanyl may be given for pain, same thing with alfentanil. Then the Demerol, same thing, pain control, and propofol is kind of more of an anesthetic agent to help them kind of go off to la la land and not really be too aware of what's going on. Okay, so the second part of this chapter, we're going to talk about local and regional anesthesia. So we'll talk about both of them, give examples, and we'll talk about some different types of regional blocks. Local anesthesia is injected at the surgical site, or it can also be applied topically. The goal of this is to interfere with sensory nerve endings in the operative area. So it's basically pain control for that surgical site. When we're talking about local anesthesia, so this just means that we're basically only going to give them local anesthesia to help them during the procedure, and there will not be an anesthesiologist. So only physically healthy and physiologically stable patients are appropriate for this. Because if somebody's not healthy, you do not want them in the operating room undergoing a procedure without being monitored by an anesthesiologist. Keep in mind too, when we're doing this without an anesthesiologist, a second nurse needs to be assigned to the room to monitor vital signs during the procedure just to make sure nothing is going wrong. And then the RN that is monitoring may also be in charge of administering sedatives as ordered by the surgeon. Some common surgical applications for local anesthesia with a MAC. So this means that anesthesiologist is going to be there and they will be present to kind of sedate them. And then they will also be giving local anesthetic from the surgical field. So the surgeon at the same time, before they make any incisions, they will be applying or injecting local anesthetic. So things like an excision or biopsy of small soft tissue masses like a breast biopsy. Those could be done in this manner. Same thing with pacemaker insertions, inserting a venous access port or catheter insertion, and placement of a dialysis access graft. All of these can be done in that manner. There are also some other applications in orthopedic surgery, head and neck surgery too. Local anesthesia can be used in plastic surgery for procedures such as excision of small lesions or minor scar revisions. Also in plastic surgery, a lot of times you'll see what's called a tumescent anesthesia. This is widely used in aesthetic surgery like liposuction. It's a special mixture of some different medications that'll be injected, and it's going to help with pain control, and it's also going to kind of help to get that fat suctioned out of there. We're going to talk a little bit about the agents used for local anesthesia. You don't have to get caught up in amnioesters and amnioamides too much. I'm just going to cover what they are. Don't get caught up in that. More than anything, I just want you to be aware of what agents are local anesthetics. But just be aware that these are classified chemically as either amnioesters or amnioamides. So the amnioesters are going to be things like topical cocaine, novocaine, benzocaine, and tetracaine. And then the amnioamides are typically all the ones you'll see in surgery, like lidocaine, bupivacaine, ropivacaine, and ropivacaine. The duration of action of these local anesthetics is due to the differences in plasma protein binding capacity. And then you'll also see some of them will have local anesthetics added. So anything that has epinephrine added to a local anesthetic will have a red on the label. So that's a quick check to see that there has been epinephrine added to it. So these are common ones that you'll see in surgery. Lidocaine is probably one of the most, it says on here most common. think that might have changed a little bit recently, but most common local anesthetic. Bupivacaine, we see this used a lot. It's about 4 times as potent as lidocaine, and it's also going to act for a longer duration. So a lot of surgeons like that because it's going to give more pain control postoperatively. Ropivacaine is going to be similar in duration to bupivacaine, but less cardiotoxic, which means it's less damaging to the heart possibly. And mepivacaine is going to be similar potency to lidocaine. Keep in mind with bupivacaine, when we say it is a little more cardiotoxic, this is because it binds to cardiac muscle. Systemic toxicity of local anesthetics is most commonly due to accidentally injecting them intravascularly when surgeons injecting them. So that's usually going to be the cause for any of the problems you see. It can affect the central nervous and cardiovascular systems, though, and the effects are very variable, anywhere from drowsiness to agitation, nausea, vomiting. Some local anesthetics may be combined with dilute epinephrine. We've talked about this a little bit before. You'll typically see these in concentrations of 1 to 100,000 or 1 to 200,000. Why doctors like to use this is because it causes a local vasoconstriction, so it slows the absorption of the agent. Basically, it keeps it in that area for a lot longer before it gets absorbed into the circulatory system. So this helps it to stay at that site longer and increases the duration of effect. And you can see the labels on the bottles here. That red, that means there's epinephrine in them. Just remember to be cautious anytime you have epinephrine involved. When it is pre-mixed in a local anesthetic, it's present in very, very low amounts. But also, we've talked about it's also separately available in high concentrations. So it's just important to label everything correctly with the concentration, so you make sure you're giving the doctor exactly what they asked for. Now we're going to talk about regional anesthesia. So this is a technique used to accomplish both sensory and motor block to an entire area of the body. So you're giving an agent injected at a nerve plexus, and that'll unblock that entire nerve bundle, and then it will anesthetize a larger area. Instead of just doing it locally, it'll give a whole block of sensation to a whole body part or area. So local and regional anesthesia, these are alike in some ways. Many of the same agents are used. You're still going to monitor vital signs for them. You still may give sedatives by IV, and the patient will be awake. There are some big ways they're different though. So they're going to have different surgical applications. In a local, the surgeon will be the one to administer the local anesthetic. The anesthesia provider will probably still be present with them, at least if you're doing a MAC, but they're not going to be the one injecting the local. In a regional anesthesia, this is when the anesthesiologist will administer the block before the surgery is even done, typically before the doctor even gets in there, and they'll still stay after that to monitor the patient's vital signs too. If you want to see how this is done, you can always go through and look up femoral nerve blocks, and it'll show you how these are specifically done. There's some videos out there. So these are different also in the fact that the administration routes are different. Regional is going to be used when both a sensory and motor block is necessary for a surgical procedure. So besides not being able to feel anything, if you want the patient not to be able to move that area of the body, that's what a motor block also achieves. So now we'll talk a little bit about specific types of regional anesthesia. Spinal anesthesia, this is when the local will be injected into the subarachnoid space, or also called intrathecally. It's going to anesthetize the entire lower body. The skin will be prepped with an antiseptic agent. A little bit of local anesthesia is going to be injected through the skin, and then they will actually go in with a spinal. It's typically quicker to administer than an epidural, which we'll also talk about, and most commonly it will use tetracaine, bupivacaine, or ropivacaine. Most often this is going to be used for procedures of the lower abdomen, perineum, and lower extremities. Be careful to watch because a drop in blood pressure can occur with administration. And then also sometimes they will leave some intrathecal catheters and pumps in to provide some post-op pain relief afterwards, or also patients with chronic pain problems. This is going to be used specifically if you want some examples of procedures, things like a resection of the prostate gland or bladder tumors, lower leg vascular procedures, select orthopedic procedures, and for C-sections. Another type of regional block is epidural anesthesia. An anesthetic agent is injected into the space surrounding the dura mater. You can see a picture of this on here as well. A little bit of local anesthetic is administered at the injection site, and then an epidural needle is placed. So this is typically used to relieve pain during labor and vaginal delivery, and it can also be used to provide anesthesia for C-sections. Typically, bupivacaine is the choice agent, either in the concentration of 1/4% or 0.5%. Sometimes you will see concentrations of 0.125 used, plus really low doses of fentanyl to provide what's called a walking epidural. So they're going to feel enough to be able to move around, but it's still going to kind of take that edge off the pain. Compared with spinal anesthesia, epidural anesthesia has less of a risk of that hypotension, less incidence of a post-dural puncture headache, and this can be given at levels above L3 to L4. So epidural is going to be preferred over spinal anesthesia when the surgical procedure is kind of variable. You don't know exactly how long it's going to take, or it's going to be a long period of time, or maybe you just want them to have some good post-op pain control. A caudal block, this is a specific type of epidural block where it's injected into the epidural space via the sacral canal. Be used for vaginal childbirth. Rarely it's used like this though. A lot of times it'll be used more in combination with general anesthesia for lower extremity procedures in children. And it can also be given for post-op pain management in select patients. You can see here the location of a caudal block, and you can look at your book if you want to look into that a little bit more as well. A peripheral nerve block is also called an extremity block. This is used for procedures on the distal arms and legs, hand and fingers, feet and toes. A lot of times, procedures on the lower extremities will use a spinal epidural instead, because otherwise they would have to use several nerve blocks to achieve that equal block that they're getting with that. Precise location of the nerve to be blocked has to be determined before actually injecting this, because the last thing you want to do is go through too deep with the needle and penetrate the nerve sheath. You don't want to damage any of the nearby blood vessels, or you don't want to unintendedly give that agent into the vascular system. So a lot of times they'll do a little test dose of the local before they inject more of the agent in small doses, and then eventually they'll get it all injected to achieve that block. The anesthesiologist may give a brachial plexus block. You can see that here. It's going to be used for procedures on the hand, forearm, or elbow. Typically they'll go through axillary. This is axillary, it's supposed to say axillary. And you can actually see on here the location of that injection. The biggest disadvantage with peripheral nerve blocks is just how long it takes to give them. It can delay surgery. Depending on your facility, they may do this in a holding area before surgery, or they may do it actually in the operating room right before surgery starts. My facility, they do it in the operating room, and it does vary widely as to who is your anesthesiologist. Some of them are so good at these blocks and they can do them really quickly, and then others are a lot slower and it can be really time consuming. So that's one of the big disadvantages. You will also see some facilities that have a separate block room where they will do this and the block will fully take effect before they even transport them to the OR, and it also kind of helps with those delays. You might see what's called a Bayer block. So this is an intravenous regional anesthesia. Your book talks about this a lot. I would advise going in and definitely reading this section of the chapter because there are some test questions about it on the final. But you can see here how this is done, all the different equipment that is used. So they will use a tourniquet, and that is basically a cuff that goes on the arm, kind of like a blood pressure cuff, but it gets a lot tighter to block blood flow, and it helps with exsanguination. You also have to have an IV catheter, syringe, and IV tubing, and local anesthetic. So what they'll do is they will get all the blood out of that limb, and then they will be able to use that tubing and catheter to put that dilute local anesthetic agent in there, and it's just going to numb all of that extremity past the tourniquet. Lidocaine is typically the agent that's most commonly used with this. Bupivacaine is contraindicated because its toxicity is most closely associated with intramuscular administration, which is what you're doing here. After the surgery is done, it's important to release the tourniquet very slowly. The most significant risk with this procedure is tourniquet failure and not having it working. And I can't ask you guys why because you're not here with me. But that is because if that tourniquet fails or you release it too quickly, you think about that anesthetic agent is going very, very quickly back into the bloodstream, blood supply, and if that hits the heart too quickly, it could be fatal. So that could be a problem. Also, you don't want to use this type of block if there's a traumatic laceration because basically you could have uncontrolled release of that anesthetic agent from the limb. A retrobulbar block, so this is something that is given specifically in eye surgery. It's going to be injected behind the eye into the muscle cone. It can be done by an ophthalmologist or an anesthesiologist. The typical injection is half to 0.75% bupivacaine and 2% lidocaine with 150 units of hyaluronidase. I didn't say that right. You guys can see what I said, it's fine. Currently, it's very rarely used. A similar technique is called peribulbar block. So that involves the injection of an anesthetic agent outside that muscle cone. So you avoid the optic nerve, but it requires more anesthetic agent and has a slower onset of action. So you're going to have to wait a little bit longer for them to get numb. And I would also make sure you're familiar with retrobulbar block if you want to read about that a little bit more in your book. So just remember, there's some different things to keep in mind with all types of anesthesia. All the patients in surgery are going to be very closely monitored, and you guys are going to be really valuable as a team member to know what's going on with the patients. If something's going awry with when they're being monitored and you hear things, tones dropping or changing, kind of perk up your ears, and if you're not scrubbed in, see how you can help or just help the surgeon, whatever role you're in. And make sure you're labeling everything because epinephrine, you will have it on your back table, so make sure you're handling it safely. Okay, we're going to skim over a couple things in advanced practices. A couple things I want to talk about are adverse effects of local anesthetics. They can be a couple different things. So clinical signs of a local allergic reaction are going to be redness, itching, swelling, any things like that. Then also you can have systemic allergic reactions. We're talking about whole body here. All over redness, all over itching, facial edema, wheezing, bronchoconstriction, cyanosis, nausea, vomiting, hypotension, and cardiovascular collapse. All of those things can mean there's something going on with the patient. They're allergic to that local anesthetic. So keep that in mind. There are chances that you might have somebody that has an allergy. Um, Overall, just remember epinephrine is added to local anesthetics because it's a vasoconstrictor, so it's going to help decrease bleeding as well as slowing down how quickly that's absorbed, so it helps with pain management. And that is it. If you guys have any questions, please let me know. But otherwise, I hope you enjoyed, and I'll talk to you next time.